Assalamualaikum. My name is Dr. Kalbe Abbas. I am a PEDS ICU physician here at the Afan University Hospital. And today we will be talking about non-invasive ventilation in children. So for next 30 to 40 minutes, our goal will be to understand non-invasive ventilation, its advantages and limitations, what are the type of non-invasive ventilation, its uses and troubleshooting in clinical setting, and then some last questions and conclusions. So I don't have any conflict of interest related to this presentation. And what basically non-invasive ventilation is, it is a technique for providing ventilation without the use of artificial airway. So the interface is at the level of nose or mouth through using masks, helmets or nasal bronchs, and ventilatory support is provided by connecting to different devices which we will discuss. It requires conscious patient and alert. Sometimes we do provide these modalities to patients who are going towards comatose condition, and we will discuss how, but technically most of the time we need cooperation of the patient for the success of these therapies, because it requires spontaneously breathing patients and spontaneous breathing efforts as compared to non-invasive ventilation. So before we go on, I'll just touch upon the basics and what are the differences between adult and pediatric airway. जैसे वो कहते हैं कि adults, children are not smaller adults. So children have high metabolic rate and high oxygen consumption, which essentially means that they are more prone to develop hypoxemia, as well as their carbon dioxide production is high. So they require these assistance in disease states more often than the adults. They have less muscle endurance, especially intercostal muscles are developing with age, so they tire off easily, and they can progress from respiratory distress to failure quickly. Then there are certain airway differences, like they have a large tongue compared to the mouth size, they have a smaller pharynx, they have large and floppy epiglottis and narrow trachea, all of which contribute to the increased resistance, which translates into increased work of breathing. So to take a breath in, बच्चों को ज़्यादा जोर लगाना पड़ता है और effort लगानी पड़ती है compared to adults. Then there is another concept which is called collateral ventilation, and as you can see in this picture, that there are some collateral channels between the alveoli and bronchioles, and as well as between different bronchioles, and these are absent in children, especially less than 2 years of age, and they are kind of mature by the age of 8 years and help in rescuing breathing in disease states, especially in adults. Also, they become the permanent respiratory channels in old ages when there is a disease like COPD or lung fibrosis. So this graph just shows the progression in time and work of breathing when a child has acute respiratory distress. So as you can see that as the work of breathing increases, children can easily progress from respiratory distress to respiratory failure, and recognition of this differentiation becomes really important in children, because our intent is to prevent them from going into respiratory failure. What are the advantages, or why do we need non-invasive ventilation? हम ये discuss क्यों कर रहे हैं? Is because there is decreased risk of laryngeal trauma associated with endotracheal intubation, ventilator associated pneumonia and tracheitis, which are all complications of invasive ventilation. Then there is less requirement for sedation and analgesia medication, though sometimes we do provide patients on non-invasive ventilation with sedation and analgesia. Then there is improved patient comfort with these interfaces compared to endotracheal tube. Then they preserve the airway defense mechanism and provide for easy pulmonary dilating, and reduced resource consumption like need for blood gas, chest x-rays, etc., as well as there is some evidence to say that children who are on non-invasive ventilation stay less in the hospital as well as in the ICU, and it is associated with improved survival. So the physiologic effect of non-invasive ventilation is that it helps to decrease the work of breathing and energy expenditure by humidifying the air, by providing some pressure support through the respiratory cycle, and decreasing the overall oxygen consumption through these mechanisms. It maintains airway patency by providing some distending pressure, especially with high flow nasal cannula, and it recruits alveoli, especially which this happens in CPAP but also in high flow nasal cannula, and this increases the FRC and decreases VQ mismatch, which leads to decrease in atelectasis. So this is also mainly characteristic of CPAP and BiPAP, but also can happen with high flow nasal cannula, and we'll be discussing that. The other physiologic effects are it leads to airway hydration because we provide heated, humidified air. So this leads to optimal humidity, which enables comfortable delivery of high flow and prevents desiccation of airway epithelium and improves mucus clearing. And it also improves mucokinesis, which essentially means that the secretions की जो मूवमेंट होती है फ्रॉम द एयरवे वो ईजी हो जाती है. सो द क्लियरेंस और पल्मोनरी टॉयलेट इम्प्रूव्स एंड देर आर लेस चांसेस ऑफ एटिलेक्टेसिस और लंग कोलैप्स बिकॉज ऑफ म्यूकस प्लग्स एट्सेट्रा. सो इंडिकेशंस क्या होती हैं नॉन इन्वेजिव वेंटिलेशन की? सो देर इज़ अ लिस्ट, बट ब्रॉडली any condition which leads to acute respiratory distress or insufficiency like pneumonia, bronchiolitis, acute asthma, pulmonary edema, these are the common conditions, but others also. Then prevention of intubation, especially in the post-operative patient. जब एक बच्चे की सर्जरी होके आई है तो immediate post-operative पीरियड में देर इज़ रिस्क कि री इंटूबेट ना हो जाएं, और आपने एक बच्चे को एक्सटूबेट किया है वेंटिलेटर से, सो देर इज़ इनहेरेंट रिस्क कि ये दोबारा री इंटूबेट ना हो, तो उसमें भी हम नॉन इन्वेजिव वेंटिलेशन देते हैं. Then hypertonic or neuromuscular disorders, children with respiratory insufficiency, or if there is obstructive sleep apnea, non-invasive ventilation at home can help in breathing in these children. And then in children who are DNR, we can provide some assistance in their intercurrent illnesses with the help of non-invasive ventilation. So contraindications. So main contraindication is a patient who has hemodynamic instability, like if a patient has presented with respiratory failure like apnea or decreased bradypnea, or if there is cardiac arrest, then it is absolutely contraindicated in patients with altered mental status, like in children who have GCS of less than 8 and are full code, or if the GCS is rapidly declining, children with facial injuries or potential for upper airway obstruction like croup or laryngitis, high risk aspiration, or if there is GI bleeding, recent upper airway or esophageal surgeries, and if there is rapidly progressive neuromuscular weakness like GBS, and then extensive head and neck tumors causing airway compromise and pneumothorax. All of the untreated pneumothorax are contraindication to non-invasive ventilation. And the commonly used non-invasive ventilation modalities are CPAP, BiPAP, and high flow nasal cannula. We will also be discussing another new type which is called non-invasive positive pressure ventilation, which is similar to mechanical ventilation, except that the interface is at the level of nose. So discussing the first modality, which is CPAP. CPAP delivers continuous positive airway pressure during inspiration and expiration, and it delivers blended and humidified oxygen. It increases FRC and recruits alveoli. It increases oxygenation and decreases the work of breathing. And what are the components of CPAP? So if you see on the right hand side of the screen, there is a blender which kind of mixes oxygen and air, and then there is a flow meter which determines how much flow the child is having, and then there is an underwater seal, and then the patient interface where CPAP can be given through a face mask, or it can be given through the nasal cushion or nasal prongs. So the gas source is air oxygen blender connected to a source of oxygen, and the pressure generator is, so there are two kind of CPAP. One is bubble CPAP. In bubble CPAP system, the pressure is created by placing the distal expiratory tubing into the water bottle, and the designated pressure is determined by the length of tubing immersed inside the water. So level of CPAP required in infants is usually between 5 to 8 centimeter of water, but it varies with the disease process, and we can go as high as 10 or above, but usually we go up from 5 to 8. There is another type of CPAP which is delivered through the ventilator or CPAP devices, and in those cases the pressure is generated through the machine. Then the patient interface, as I mentioned, can be nasal prong which are tightly fitting, or it can be a face mask. The important consideration here is the formation of seal. If there is no seal, then CPAP does not deliver the PEEP which is required to prevent atelectasis and improve FRC. Coming on to the BiPAP, BiPAP it basically provides two pressures: inspiratory positive airway pressure and expiratory positive airway pressure, and during the different phases of inspiration and expiration. And interface can be, again, it can be nasal mask or nasal pillow, it can be oral face mask, or it can be helmets. So BiPAP, usually we start with settings of 8/4. Maximum IPAP we go up to 20 to 25 centimeter of water. EPAP is 10 to 15 depending on the condition. There are two types of machine. In one machine we connect oxygen and provide oxygen in liters per minute flow, which means that we start with 5 liters of oxygen, and depending on the condition we can go up to 10 or 15 liters of oxygen. And in other machines there is a blender and a calibrator through which we can determine that how much fractional inspired oxygen we are giving in terms of percentage. So usually we start with higher FiO2 in those settings. And in some patients we set up a backup rate appropriate for age and disease, and in some setting we just put it as spontaneous, that the machine coordinates with the patient own respiratory efforts. As I earlier mentioned कि इन बच्चों में they should be spontaneously breathing, तब ये नॉन इन्वेजिव वेंटिलेशन काम करती है. अब एडजस्टमेंट कैसे करते हैं? इफ़ वी आर डीलिंग विद हाइपरकैप्निक रेस्पिरेटरी फेलियर, देन टाइट्रेट IPAP अप टू 2 सेंटीमीटर इंक्रीमेंट, आप उसको बढ़ाते जाते हैं. एंड बेसिकली वी इंक्रीज द IPAP EPAP gradient, while in hypoxemic respiratory failure we titrate EPAP up in 2 centimeter increment, and we keep IPAP EPAP gradient the same. So both IPAP and EPAP must be increased in hypoxemic respiratory failure. We do not increase IPAP or EPAP beyond the patient tolerance, because जब हम बढ़ाते हैं तो it sends the air flow with the certain amount of pressure which is felt at the nose and face mask के interface पे, or that can become uncomfortable for the patient. And high pressure also increases the possibility of gastric distension, जो कि result करती है in aspiration का risk and decreases diaphragmatic excursion. High flow nasal cannula, it basically provides heated, humidified and blended air oxygen delivery via nasal cannula at different flow rates. It is delivered both high concentration of oxygen and potentially continuous descending pressure. It leads to excretion, clearance of excretion, prevents obstruction by delivering distending pressure, and it also provide conservation energy expenditure by providing heated and humidified air. And on the right hand side, you can see a setup where you can see a flow meter, an oxygen blender, a humidifier, a humidified circuit, and then a nasal cannula, which is the interface in the form of high flow nasal cannula. So initial flow is age dependent. In younger children, we go up with 1 liter per kilo up to 25. In older children, we go up to 25 liter, and in younger children, we go up to 8 liters by 2 liters per kilo. FiO2, we start with lower FiO2 and titrate to keep the saturation 92 to 99%. And temperature we set 1 to 2 centimeter below the body temperature. So usually 34 से 37 के बीच में हम initial temperature रखते हैं in case of high flow nasal cannula. So this is the fourth type which I discussed earlier. It provides inspiratory and expiratory support during using the same principle of mechanical ventilation, and the interface is RAM cannula. RAM cannula is similar to nasal cannula with differences. It can adapt to the ventilatory circuit, it can adapt to the CPAP circuit, and it can adapt to the nasal cannula, high flow nasal cannula ka circuit. And so the only difference between invasive mechanical ventilation and NIPPV is the interface, and this interface is can be mask, it can be nose. In our hospital, we use nasal interface, and there is some initial evidence and experience that this modality is useful, and it can help in children where CPAP or high flow nasal cannula have failed, because it provides bi-level ventilatory support. So additional points and tricks for non-invasive ventilation is that ये जो 12 महीने से कम बच्चे होते हैं, non-invasive ventilation such as BiPAP is probably not a good choice, since most available machine cannot reliably sense respiratory effort in such younger patient, because इनका inspiratory flow बहुत थोड़ा होता है. So pediatric specific machines अभी हैं नहीं. Nasal continuous airway pressure is better choice in very young infants because of better tolerability, and HFNC is better tolerated in both very young infants and older children. And for patients on BiPAP with mixed respiratory failure, address oxygenation first if needed. So increase EPAP to achieve SpO2 and PO2 goal, and then increase IPAP EPAP gradient to achieve our hypercapnia ka goal. So this slide is very important, and I'll spend some time here to understand the differences between CPAP and BiPAP and high flow nasal cannula and CPAP. So CPAP provides same pressure during the inspiration and expiration. BiPAP provide different pressure during inspiration and expiration, and there is a difference. CPAP improves functional residual capacity that leads to less atelectasis, more oxygenation because of better gas exchange, and it is a less complicated device. BiPAP, on the other hand, also improves ventilation, and it needs monitoring of delivery of pressures from the machine. Coming on to the high flow nasal cannula and CPAP. So in दोनों में जो major difference है, CPAP high flow is only high flow without any pressure. There is some research जो कहते हैं कि ये थोड़ा सा पीप जनरेट करता है, but its major principle is only flow. Flow जब आप देते हैं तो ये 2-3 काम करता है. One is म्यूकस की जो हैंडलिंग या डायनामिक्स होते हैं उसको बेहतर करता है. डेड स्पेस को फ्लश करता है, जो हमारी फिजियोलॉजिक डेड स्पेस होती है, एंड इवन एनाटॉमिक विद फ्रेश एयर. सो जो वेंटिलेशन है वो बेहतर होती है, एंड देन इट प्रोवाइड्स डिस्टेंडिंग प्रेशर. सो उसकी वजह से जो वर्क ऑफ ब्रीदिंग है वो इम्प्रूव होता है. So CPAP basically provides flow generated pressure. So it is flow generated pressure सो इसकी वजह से इसको सील चाहिए होती है, अगर सील नहीं होगी तो वो CPAP डिलीवर नहीं होगी। हाई फ्लो में इट इज़ अपोजिट, यू डू नॉट नीड टू हैव अ सील। अगर वो सील बन गई किसी भी वजह से, दैट विल लीड टू मोर इंसिडेंस ऑफ बैरोट्रामा एंड वॉल्यूट्रामा। एयर दोनों में हीटेड ह्यूमिडिफाइड होती है। HFNC में फ़्लो कैपेबिलिटीज़ होती हैं एंड वी कैन गो अप एज हाई एज 25 लीटर्स, वाइल नेज़ल CPAP में इट इज़ फ्लो ड्रिवन पीप। सो हम फ्लो को बढ़ाते हैं टू अचीव सर्टन पीप। आवर टारगेट इज़ पीप एंड विच इज़ 5 to 8 सेंटीमीटर ऑफ वाटर अप टू 10 सेंटीमीटर ऑफ वाटर। और जब हम इसको CPAP को टाइट्रेट भी करते हैं, वीन भी करते हैं, तो वी ओनली वीन CPAP और PEEP, वी डू नॉट वीन फ्लो, जबकि हाई फ्लो में हम फ्लो को वीन करते हैं। HFNC इज़ सिंपल एप्लीकेशन वाइल CPAP इज़ ऑपरेटर डिपेंडेंट, कि वो बार बार आपको बच्चे को देखना पड़ता है कि सील तो नहीं टूट रही या कोई और प्रॉब्लम तो नहीं हो रहा। लेस नेज़ल ट्रामा इन हाई फ्लो, देर इज़ रिस्क ऑफ नेज़ल ट्रामा इन CPAP बिकॉज आपको सील चाहिए होती है, स्पेशली यंगर इन्फेंट में सेप्टल परफोरेशन का रिस्क होता है अगर लंबे ड्यूरेशन के लिए दें। इसलिए इसकी वजह से हाई फ्लो इज़ मोर कंफर्टेबल एंड लेस चांसेस ऑफ एयर लीक कंपेयर टू CPAP। सो मॉनिटरिंग कैसे करते हैं इन बच्चों को ऑन नॉन इन्वेजिव वेंटिलेशन? सो बेसिक मॉनिटरिंग इज़ अ वाइटल साइंस लाइक हार्ट रेट, रेस्पिरेटरी रेट, ऑक्सीजन, वर्कअप ब्रीदिंग, कॉन्शियसनेस, कंफर्ट, pH एंड PCO2। फिर आप ब्लड गैसेस भी कर सकते हैं डेली या 2 times a डे डिपेंडिंग ऑन द सिचुएशन। आप चेस्ट एक्सरे भी कर सकते हैं। सो और हाउ डू वी डिटरमिन कि पेशेंट इम्प्रूव हो रहा है या नहीं हो रहा? सो इफ़ देर इज़ इम्प्रूवमेंट in heart rate, in respiratory rate, in oxygen and in workup breathing after 1 to 2 hours, you have to give these patient at least 1 to 2 hours depending on how the child is doing. If the patient is improving or not deteriorating, you can continue, but if there is no response in 2 hours, then you know that the patient is not responding and you have to go to the next step or escalate the therapy, and then either you go on to NIPPV or you directly go and intubate these patients. वीनिंग भी अगर हमने जिस तरह बात की, इन CPAP कैन बी ट्रायल्ड वन द पेशेंट हैज़ बिन स्टेबल फॉर एटलीस्ट 12 to 24 hours एंड वी डिक्रीज़ द पीप, वी डू नॉट डिक्रीज़ द फ्लो अगर बबल CPAP यूज़ कर रहे हैं। और जब 5 या 6 की पीप आती है देन वी कैन स्विच इट टू, और FiO2 40% है तो वी कैन स्विच इट टू नॉर्मल नेज़ल प्रोंग। इन हाई फ्लो नेज़ल कैनुला आफ्टर स्टेबिलिटी फॉर 12 to 24 hours, जब पेशेंट स्टेबलाइज हो गया विद normal oxygenation, ventilation and workup breathing, so we start decreasing flow 1 to 2 liter up to 4 to 6 liters, and then and FiO2 30 to 35% के बीच में आ गई है, so we switch it to nasal prongs. What could be the disadvantages or complication is airway is not secure, तो वो aspiration का रिस्क होता है, respiratory arrest का रिस्क होता है, slow, it takes some time to correct the blood gases, there is no direct access to the bronchial tree, so suctioning जो हम ET से कर सकते हैं वो इससे नहीं कर सकते। Tracheal suction require removal of the facial mask which can lead to respiratory decompensation during those periods, अगर हमें sectioning की बहुत ज़्यादा ज़रूरत है। Then there is risk of air leak, CPAP के साथ भी हो सकता है, high flow nasal cannula के साथ भी हो सकता है, especially अगर सील बन गई है। Increased risk of aspiration as discussed, and risk of skin breakdown over the nasal bridge in case of, especially in case of CPAP, and then restriction of activity or sometimes sedation often needed to maintain normal mask key placement. What are the predictors of success? So 3 key predictors of success जो आपने याद रखने हैं। One is if the FiO2 at start at 1 hour is same or there is an increasing requirement, then there are chances that this patient will not tolerate or the NIV will be unsuccessful. If the workup breathing, especially the respiratory rate, is continuously worsening on non-invasive ventilation. And then third is a more objective measure which is called ROX index, and ROX is basically SF ratio divided by respiratory rate. So if this is between 5 to 8.5 has the highest prediction कि बच्चा ये फेल करेगा या नहीं करेगा, सो इसको भी आप यूज़ कर सकते हैं, बट मोर डाटा इज स्टिल नीडेड टू कंफर्म इसकी एक्यूरेट एंड एग्जैक्ट वैल्यूज़. So this is just a general algorithm for children who have presented with acute respiratory distress or failure. So if there is hypercapnic respiratory failure, you do the blood gas or you see कि ये कौन सी कैटेगरी में हो रहा है. If there is mild to moderate respiratory failure है, pH बहुत ज़्यादा डिस्टर्ब नहीं है, you can go and try non-invasive ventilation. Otherwise you directly go and provide them invasive ventilation. In between you can give a trial of non-invasive ventilation with time limitation. And if this is hypoxemic respiratory failure and the patient is overall stable hemodynamically with good GCS, you can go ahead, start NIV and then see can NIV succeed ho raha hai ya nahi ho raha. But if the patient is comatose, hemodynamically unstable or some facial abnormalities, then go ahead and intubate these children. Some tricky scenarios. So say there is a patient on BiPAP which is not improving and you continue the therapy to avoid intubation and adverse effect. So what will be your response? So as I mentioned that when you put these patients on non-invasive ventilation, that is not the end of the story. In fact, that is the start of the story. तो आपने उनको monitor करना है, give them some time, at least 1 to 2 hours, see if the oxygen requirement is increasing, if the work of breathing is increasing, then it is the time to go and intubate them and do not wait more. Another scenario could be a patient is placed on HFNC and he continues to breathe fast after 15 minutes, so you decide to intubate. So as I mentioned in the above scenario, at least 1 to 2 hours, 15 minutes is too quick of a time. So बहुत जल्दी भी decision नहीं लेना, wait some time, keep things prepared and see if this rate of respiration is continuously increasing, then you can decide to intubate at 30 minutes or 45, but 15 is too much less time to take the next step. Third is a child with suspected VSD comes with pneumonia and you start him on CPAP. So remember, अगर आप bubble CPAP दे रहे हैं, this is oxygen driven CPAP, which means कि patient जो भी breathe कर रहा है वो सारी oxygen है. And in VSD patient, when you will give oxygen, that will lead to more shunting, that will lead to heart failure, and that will lead to worse work of breathing. So in children with acyanotic congenital heart disease who have increased left to right shunt, avoid giving them a modality which only relies on oxygen. So in summary, non-invasive ventilation, it is an effective bridge to non-invasive ventilation, to invasive ventilation before or afterwards. Simple and effective way of managing most of the respiratory distress in children. It supports oxygen and ventilation and helps to reduce the work of breathing. Careful selection of patients as well as appropriate delivery mode or modality is important, and vigilant monitoring during NIV is mandatory. Also know your limitation where you are practicing and be vigilant and always have a plan B and decide timely when to intubate. So and the last point is that just to re-emphasize that in younger children, especially less than 2 years, CPAP is a good modality. Although HFNC is tolerated well, for adolescent we do have the mask and the machine. BiPAP is an excellent modality. In between की ages के लिए you can use high flow nasal cannula, and sometimes if high flow nasal cannula or CPAP is not working, then NIPPV helps to bridge, and we have seen patient not requiring intubation in such situation. So with this, I will end my presentation. I have my email. If you have any questions, please feel free to write to me and we will get back to you. Thank you so much. So, So